Hello, welcome to case-based learning of cardiac MRI on mricardiac.com. Young female presented with history of syncopal attacks and ventricular arrhythmias. There was family history of sudden cardiac death in first degree close relative. ECG and echo findings were abnormal. And because of that, cardiac MRI was suggested for further workup. These are 4-chamber cine images of cardiac MRI, and it reveals dilated right ventricle with this crenated or crumpled appearance of free wall. Short axis cine images, it reveals segmental dyskinesia involving free wall of the right ventricle, and also note these small microaneurysms which are seen over here. 3-chamber view of cardiac MR shows enlarged right ventricular outflow tract. RV function is also significantly reduced. It is 38%. So this is RV function is usually obtained either on 4-chamber or short axis views, and both the ways can be used. 4-chamber ways has an advantage that it can define the tricuspid annular plane more clearly, while short axis images is the same stack which you use it for the left ventricle. The same stack of images can be used. And as you see over here, RV function is reduced, and end diastolic volume, this is indexed end diastolic volume, which is also significantly increased. So all these features are suggestive of arrhythmogenic cardiomyopathy. So it is very rare and genetically determined cardiomyopathy. It is autosomal dominant with variable expression. And MRI has an advantage that it can even detect early or concealed cases of ARVC. The clinical presentations may be highly variable, but MRI features with RV ejection fraction, end diastolic volume parameters, and segmental dyskinesia are highly characteristics, and it can detect these cases. Initially, it was thought that fatty or fibrofatty tissue in RV free wall is diagnostic, but however, now without fat in the myocardium can occur even in normal patients, hence it is not considered as diagnostic, and without absence of wall motion abnormality or functional parameters, this should not be considered as diagnostic. So basically, this is the triangle of dysplasia, one of the earliest site where the ARVC foci can be seen, and functional and morphologic abnormalities are most commonly found in this triangle of dysplasia. What happens over here that the fatty and fibrous tissue replaces the normal heart muscles. And because of this, there is interruption of normal electrical signals, which causes irregular and life-threatening arrhythmias. Heart muscle gradually becomes weak and finally leads to heart failure. Usually it starts in right ventricle, but can also extend to left ventricle. And in case if there are phenotypes, it can involve primarily left ventricle as well. So now it is called as arrhythmogenic cardiomyopathy with LV or RV involvement. This commonly presents between age of 10 to 50 years of age. Males have slight predominance. Symptoms can be highly variable depending on the arrhythmia. Patient can have fainting, palpitations, dizziness, fatigue, shortness of breath, and unfortunately, sudden cardiac death can be just the first presentation in few cases. Detailed family history and genetic workup may be required. And as I mentioned earlier, the left ventricle can either be involved along with RV or even isolated LV involvement has been reported. The diagnosis is used based on multiple methods. It is not with one test. You have to evaluate for global systolic function and restructural alterations, which can be done by the echocardiography and MRI, tissue characterization, ECG abnormalities with repolarization and depolarization abnormality, any presence of arrhythmias on Holter monitoring, and family history. So depending on the ECG, Holter, type of arrhythmia, looking at family history and echo and MRI findings, ARVC can be detected, diagnosed. So the diagnosis is also basically by obtaining, there are different ways in which obtaining major and minor criteria. So it is multifactorial. In case if there are two major criteria, it will be definite ARVC, and depending on this is how it is. So in our case, basically there was MRI findings in which there was regional RV akinesia, or dyskinesia with dysynchronous RV contraction, and one of the following. So basically, ejection fraction less than 40% or end diastolic volume more than 110. So our patient had one major criteria on MRI, and there was one minor criteria with premature sudden death in family, first degree relative. Patient also had ECG abnormalities and arrhythmias which were consistent with these findings. So definitely she had one major and two minor criteria. So the diagnosis of ARVC was confirmed. In case if you do not have these criteria, you may have to call the patient as borderline ARVC or possible ARVC and then ask for a regular follow-up. So again, going through imaging criteria, especially for MRI, remember that it is regional RV akinesia or dyskinesia, as we had seen earlier, those small micro aneurysms, along with any of these quantitative parameters. That is RV end diastolic volume more than 110 in male and more than 100 in female, or RV ejection fraction of less than 40%. So it is dyskinesia which has to be there along with any of these parameters. Similarly, for minor criteria, it is again RV wall akinesia, dyskinesia has to be present along with this, any of these ratios. Again, 110 in male and less than 100 in female, and RV ejection fraction between 40 to 45%. Also, please note that these are indexed volumes as per the body surface area. ECG wave are characteristic of ARVC, which is termed as an epsilon wave. And as you see over here, that in epsilon wave, basically there is widening of QRS. So this is QRS complex, and then you get a small another peak before the T wave, and that is known as epsilon wave. So this is characteristic of ARVC. Now, as we know that RV assessment is always difficult on 2D echo, and hence cardiac MRI provides better evaluation. Cardiac MRI gives you RV size, RV function. It assesses LV involvement in case if there is any abnormal myocardial structures, any fibrosis, and it also rules out any other causes of RV dilatation. So whenever there is a suspicion of arrhythmogenic cardiomyopathy, cardiac MRI has an important role. You also have to remember few potential pitfall, especially this kind of RV free wall tether. Basically, this is an anatomic variant. Sometimes what happens is that pericardial connective tissue joins the anterior wall of the RV, and you may just get potential tethering. However, chest wall deformity like pectus excavatum can also result in alteration of the shape of the RV, and that also should not be mistaken as an abnormal finding. There are challenges in diagnosis and management of these patients because the signs and symptoms are variable and they develop over time. There is variable penetrance, and sometimes, unfortunately, sudden cardiac death can be the first presenting symptoms. This cardiomyopathy has overlap with other hereditary cardiomyopathy, and you may get this borderline features of right ventricle on few of the cases. And unfortunately, no single test is gold standard. Hence, it has to be seen as complete whole along with clinical ECG, echocardiography, and MRI findings. Management is depending on the stage of the disease. If it is, there are arrhythmias which are treatable, you can treat with medical management. And in case if there are more occurrence, then AICD implantation can be planned. Genetic screening and regular follow-up is essential. And unfortunately, in few cases, heart transplantation will be the last resort. Similar concepts can be found on our book, Cardiac MRI Simplified. You have any feedback or suggestions, please mail us on info@mricardiac.com. Thank you.